Good morning, everybody. Brian Laneau, Connecticut State Representative, District 45, comprising of 5 towns in eastern Connecticut, Griswold, Sterling, Voluntown, a portion of Lisbon, and a portion of Plainfield.
Thank you. Go ahead.
Good morning, everyone. I'm Deborah Dorfman. I'm the Executive Director of Disability Rights Connecticut.
Good morning, everyone. I'm Mike Wilby, Community Engagement Advocate for Disability Rights Connecticut.
Hi, I'm Pam Fields. I am the CEO at Mid-State ARC and the Assistive Technology Training Center and a member of the committee.
Is there anybody in the Zoom that would, if they can, if it's possible for them to give an introduction to themselves?
Absolutely, and thank you. My name is Doris Maldonado, and I am the statewide bilingual health information specialist for parents available to help throughout Connecticut. I am also the Developmental Disabilities Council Vice Chair, and I am the guardian ad litem for children in placement as well as a certified teacher. Thank you.
Thank you. Anybody else?
Yes, good morning. This is Phil Young, State Representative from the 120th. This is one of the great things about this hybrid is that I can go to my events that I'm supposed to go to at 12 and not try to scream home from the Capitol. So thank you for having us.
Thank you, sir. Yeah, anybody else?
Hi, my name is Wynn Everts. I'm the Executive Director of the ARC Connecticut.
Thank you, Wynn. And
Kevin Bronson with DDS.
thank you, Kevin. Is there anybody else? Okay, thank you to everybody who gave themselves an introduction. We're gonna go right now into the presentations. And I just want to let everybody, the ones who are giving presentations, if you can kindly leave enough room for if anybody has any questions. Thank you very much. And the first one up to bat is Pam Fields, who's the Chief Executive Officer for Mid-State ARC. Okay, thank you, Pam. Go ahead.
Yes. So will I be presenting from here, or are we showing my presentation, or? Either way.
You begin. We have a new arrival. Would you like to introduce yourself, ma'am? Thank you.
So good morning, everyone, fellow committee members and guests. I've been asked to give you a presentation on the ATEC Center and what our goals are for people with barrier issues, including those with behavioral and medical challenges and/or aging. In 2014, Mid-State ARC began utilizing assistive technology to enable people living in our group homes to move into more independent living settings. And to help us in this endeavor, we created the Assistive Technology Training Center as a resource to ourselves and made it a membership agency to be a resource for others looking to build their knowledge and their use of assistive technology. As we move through the past several years, utilizing assistive technology to assist people to become more independent, we have come to the conclusion that for many of the people we provide supports for, living in their own space is the best place, and it provides the best opportunity to live fully in their community. For people who cannot make that leap into living in their own smart apartment, assistive technology also affords them the opportunity to become more independent in their family homes and other residential settings. It is the most effective way to provide the exact supports each person needs. It is a combination of natural family supports, staff support, and technology. You can go to the next slide. The Assistive Technology Training Center is a valuable resource for people looking to learn about assistive technology, and it is entirely connected remotely no matter where the need is. It is a cooperative center where members can learn from each other. The outcomes of the center include more knowledge and skills for members and greater independence for the people we support throughout Connecticut. Our center offers assessments to identify the barrier issues to independence, a lending library to borrow equipment to try out and to assure it addresses the barrier before it is purchased, installation of the equipment, training on the use of the equipment, follow-up for sustainability, along with a variety of other training opportunities. You can go to the next slide. Thank you. Most of the people we support have already gone through the learning process for most tasks and have been unable to gain some of the skills or part of the skills, such as reading, writing, money management, staying on task, other executive functions. We have a slightly different angle, and an example of our process for assistive technology assessments at the ATEC Center is that if you cannot read, our AT professionals would not be looking at teaching you how to read, but we would be looking at finding a device that would read for you. We come at it from a different angle and concentrate on the barriers to performing a task, not the missing skills. We look for the most simple, straightforward tools that will get the job done and be the least invasive solution. Anyone with a barrier issue, including seniors and people with complex behavioral and medical needs, can benefit from the use of assistive technology. We have helped people with the level of needs 1 through 7 become more independent. Families benefit because they can use the assistive technology to help them manage the routines of the home and the family. You can go to the next one, please. There are certain diagnoses and behaviors that would prevent someone from reducing their in-person staffing ratios to truly living independently. These behaviors and diagnoses include actions that would require immediate staff intervention to ensure everyone's health and safety and could not be addressed by any other method. Such diagnoses and behaviors include, but are not limited to, predatory behavior, pyromania, severe injurious behaviors, bolting and AWOL without safety skills, uncontrolled seizures, lack of social sexual safety skills, Prader-Willis, uncontrolled pica, uncontrolled aggressive or dangerous behaviors, and medical needs that require immediate intervention, such as tracheotomies. However, even though some people cannot access technology to live totally independently, they and their families can benefit from the use of technology in their current environments and may be able to achieve moments or hours of independence. For people who always rely on human beings for 24-hour supports, there is assistive technology that can help them be more independent and self-reliant in that environment. Some of the assistive technology includes video communication or telecommunication devices, sensors for incontinence, sensors for movement alerts, cameras, computers and tablets for activities and gaming, and for organizational skills, medication administration devices, assistive technology for cooking safety, staying on task apps, activities of daily living, GPS tracking devices for bolting, communication and translation devices, and reading devices. These are just a few of the types of assistive technology that each situation is so individualized, and these tools would need to be identified through an assessment by for each person. You can go to the next slide. Thank you. Using assistive technology in your home can help you with monitoring while the caregiver is doing their own personal needs, showering or bathing, while someone is sleeping, while you are working outside when the person you need to keep an eye on is inside, while you are running an errand or managing different levels of a home, even while you are caring for another child or family member. Assistive technology Also helps manage, as I mentioned before, in these environments, stove safety. There are devices that you can make sure the stove does not get turned on. You put the device on and it keeps the stove turned off. So if a child or an adult would go over to turn on the stove, it wouldn't allow it to have access. Elopement issues, communication and translation, and recreation and gaming during those times. So we have many success stories, not only moving people who are expected to live independently into their own smart home, but also success for people who never had the option to live independently before. On the screen, on the right, you can see Morris. He is a gentleman who has always had lived in a 24-hour congregate care setting and rarely came out of his room. Usually he came out of his room on a change of shift to see what staff was working, or if he wanted to get his roommates going. That was the time he would do that. He has multiple diagnoses for a variety of different behavioral and medical issues. Although he does not have any of those behaviors or diagnosis that I mentioned on that previous slide. Through a rigorous assessment and trial period, he is now living in his own apartment successfully with 36 hours of staffing and an overnight staff that is available nearby, not in his apartment, but should there be an emergency, they're monitoring him through a remote monitoring service. They would be able to interact with them if they need to, either through video or coming over to his apartment if they needed to help him with that. And he now regularly visits his community. He's lived in this environment for a couple years successfully and is doing quite well. The other woman you see on the screen is Annie. She has complex behavioral needs and was requiring a 2-person floor control several times a week while living in the group home. The clinical team felt that a lot of her behaviors were stemming from the environment, and that if she could just live in her own place, she would be more successful. We were finally able to work with DDS to start a trial for her. We moved her into her own apartment with cameras and remote monitoring services and stove safety buttons and door locks and video doorbells. She was not able to pass her own meds, so she wasn't using electronic med minders. She now lives in her own apartment with 56 hours of staffing and natural family supports on the weekend. She has not had the need for physical intervention in 3 years, and she's doing very well. Barry is another individual I wanted to share with you as a story. Barry, who is not pictured on the screen, I didn't have a picture of him. He lives in his in an apartment with 24-hour staffing. He was living in an apartment with 24-hour staffing. He was losing the use of his hands. He had very good verbal communications, but he did not have good hand control. And so he wasn't able to call for help. He wasn't able to answer his door or call for an emergency. So he wasn't able to stay alone. So we worked with him through an assessment. We were able to help him with a variety of technology, including a self door opener, an automatic door opener, a video doorbell, electronic door lock, a phone, smart lights. They were all connected to an Alexa show. He was able to stay in his house. He was able to answer his door, unlock the door, let the person in, lock the door when they left, turn on and off his lights. He had a special cup attached to his wheelchair, so he would have drinks the whole time he was there, and he was able to stay independent for 2 hours at a time. And he was just so excited that that allowed him that access for him. You can turn to the next slide. Thank you. I'm almost done. Our goal at the Assistive Technology Training Center is to help as many people as possible become as independent as they can, whether it is in their own home, staffed in a staffed environment, or in their family home. And if anybody has any questions, me and Amy can take those questions. And sitting next to me is Amy, and she works with me at the Assistive Technology Training Center.
Brian, if you'd like to go ahead and ask the first question.
Thank you, Mr. Chairman. Good morning. Thank you, Ms. Fields, for being here and for that presentation. Just one quick question I'm curious about. You mentioned a gentleman, for example, that is in a 24-hour congregate care, was able to get into the smart home with this technology. People who are in those settings that require 24-hour care, that so they can get shifted perhaps into a smart home or more this type of technology, adaptive living. what's the criteria within that population or assessments that are looked at to evaluate people within that population to see if they're eligible to at least try to be put into the setting?
Right. So it's very, very individualized. How we do it at the center is, and DDS works closely with us to fund the assessment process. So we meet with the team to talk to the team about the person's ability to possibly live more independently. So if they don't have any of those other behaviors that would prevent them from living independently, then we can start the process. And what we usually do is we do a full assessment looking for all of their barriers. We do an independent living assessment also. And then once we've identified what those barriers are when they're living in a 24-hour setting already, we install the equipment in the home that they're in now, and we start doing trials where they live now safely. So with Morris, who you saw, we installed all of the equipment, the remote monitoring pieces, the sensors, all of the things he needed in his group home. And while his roommates were either out at work or out they'd go away for the weekend, or they would be out of the house, we would conduct trials in the house of Morris staying alone. We would conduct all of the questions that the team has. What happens if he's alone? What happens if there's a fire? What happens if somebody calls, all of those situations. And we set those up to happen while he's there alone so that we can train him and get the pieces of technology that will address the issues that he maybe can't learn. One of the things with Morris is he wouldn't answer the door. We would send strangers to the door, people he knew to the door. He would not answer the door. Once we got him the video doorbell, he would answer the door from his tablet. So as you're doing the trials, you'll learn what works and what doesn't work. So the team as a whole makes that decision, whether you move forward into independence or not. And there's no one piece fits all. It's so individualized for each person.
You mentioned some of you look at barriers which prevents people from living independently. What's some of the most common barriers that you found during this process?
So we have used electronic med minders to help people. It's a MedMinder John is what it's called. And it is a med box that is holds either a week's worth of meds or a month's worth of meds, depending on how much, meds you have. And what the device does is it unlocks and lights up the box that the person needs to take their meds out of. If they don't take their meds out, it calls them on the phone. It calls them first and says, you need to go take your meds. If they still don't take your meds, then it can call a caregiver. So if we have somebody that struggles with remembering to take their meds or knowing the right meds to take, this box can be pre-poured. And then each time they need their meds, that one box would open up and they'd have access to that one med. If for some reason they didn't take their med during a certain amount of time, it would relock the box so they couldn't double take if the next one opened and somebody hadn't gotten there to check on that. It depends on the, if it was a vitamin or something and somebody didn't go in to make sure they got their meds. Usually what happens with us, we have a lot of people using these devices. And if for some reason they didn't take their meds and we got the call, the staff would then report to the house and work with them to take their meds. There's also a stove safety that has artificial intelligence that attaches to the stove. So if somebody would walk away and forget to go back to the stove when they were cooking, this device knows when you're standing there. And if you walk away from the stove, it starts beeping. And if you don't return, it just shuts the stove off until you return. That device can also be used to keep the stove off when staff isn't there. If it's somebody who can't use the stove while nobody's there, it just keeps the stove off until a staff is there to turn the stove on. So there's just so many different devices. If somebody can't use a key to get into their department, you can put a door lock on that does a thumbprint open for them, or does a key fob or a card, or they even have the eye scans for the door locks now. So it really, one of the things that Morris did, I said before that he liked to stay in his bedroom and wouldn't go out. So when he got into his own apartment, all of a sudden he was leaving the apartment and going down the street. So we got him a pair of GPS tracking soles so that we could see where he was going when he went around. And he went over to the high school. They had the marching band there, and he would sit there and watch the marching band and the football He wanted to just, he's a people watcher. So he would go find groups of people and he'd sit and watch them and then he'd go back to his apartment. So he doesn't need the GPS tools any longer because we know really where he's going. But we did put those in place when we saw new behavior.
Thank you, Ms. Fields. I appreciate your answers.
Doris has a question. Yeah, I hope she can give it. Go ahead, Doris, you have a question.
Thank you. I would love for Pam to possibly also, she didn't mention, but the Developmental Disabilities Council has launched our 5-year plan and for the IDD communities statewide. And we have an RFA for the Mid-State ARC as well as Keep the Promise Coalition. And we have we are working on establishing supports and networks for Connecticut People First as well as Proud Parents. I'm wondering how this task force, I'm actually saddened that we weren't contacted, the council wasn't contacted or wasn't made aware of this meeting. I found it by way of 3 emails reaching me this morning. So if Pam can elaborate or can share with the task force her initiatives and Mid-State ARC, we are very proud of this initiative moving forward in the next year.
Thank you, Doris. I'd be happy to do that. So we're working with the council to provide an independent living conference with the use of assistive technology for providers and families and people throughout our system who are interested in that type of service. This would really work to give families and providers tools on how do you go about starting this process. How do you find technology? What's out there and available? We're working cooperatively with a bunch of different agencies. So we're expecting to have the Association for Community Living, which is a national organization. They're hopefully going to present at the conference. We have a national speaker, Tom Pomeranz, who talks about change and risk and people living independently and doing things in the community. He's going to be coming in and presenting at the conference, and CMS. So we're hoping to have, it's a 1.5-day conference in Connecticut next July. And, there'll be more information coming out. So we were very excited to work with the council to be able to provide this resource for everybody throughout Connecticut.
Is there anybody else that has any? Oh, go ahead, Milo.
Thank you so much for just giving us an overview of assisted technology. One of the questions I have, because on my form it says you're the Chief Executive Officer of the ARC. So do you oversee beyond assisted technology as the entire organization?
Yes, I'm
Okay.
the CEO of the organization and the founder of the Assistive Technology Training Center.
Okay. So I know one of the things that I'm finding most overwhelming on this committee is that this is such a broad task that we have. There's so many different, as you said, you're serving level of need 1 through 7. So I think that we really need, as a committee, to narrow down to the most significant needs that we're facing as a state right now and simplify so that we can actually get things accomplished. And I can appreciate that assistive technology is a great solution for many people to live more independently. But what would you be able to share with us as like your number 1 and number 2 most significant needs right now that are facing this population?
Which population are you talking about? People who want
Adults
independent
with
living?
disabilities.
Adults with disabilities.
So because you serve such a spectrum, I'm interested in hearing to get a baseline of what the most significant needs are that you're seeing.
Right. I think the most significant needs are employment for the people we provide services for. And I also think it is to become as independent as possible. Our system, I feel, really feeds segregation. And we really need to learn how to set up separate new programs and new ways of providing services that connect people to their community and allow them to live as independent as possible. As we move forward with it at Mid-State, that's why we started the Assistive Technology Training Center to help us in that endeavor.
Do you see a lot of abuse and neglect cases across the board that are concerning for this population?
I think that there's always situations where that occurs when a population is can be, and I'm trying to think of the right words, when they can be victimized. I think it happens, and we have to be vigilant and provide such, as much internal controls and controls in the situation to try to prevent as much of that as possible.
So staffing probably would be the response to everything. Proper staffing, education for staffing to help those that are most vulnerable. Is that accurate?
I don't think it's just staffing. I think it's a whole arc of services. I think it has assistive technology, it has family supports, it has staff supports, it has community supports, it has specialists, your psychiatrists and your medical staff. I think it's a whole village. It's a whole group of services to keep people safe. It's not just one answer.
Representative Young, you have a question, sir?
Thank you, Chairman. Just more of a nuts and bolts issue on what's going on right now. How are you guys doing this? Obviously, it's very labor intensive. How are you guys doing in terms of having enough people to fill these jobs? And how do you see that? And we're seeing great technology and great things happening. And where do you see that going in the future? Because it is such a labor intensive thing. And how do we facilitate this better? So thank you.
I think the way we approach it is to train all of the providers and their staff on these skills. It's not something that we're going to do as the assistive technology for the entire state for everyone. The purpose of our center is for everyone to learn these skills. It gives you the knowledge so that we're all working toward it. We're all learning how to assess people. We're all learning how to find the technology. We're all learning how to do all of those pieces because no one person can do all of it. And what happens when one person says they can do all of it, they come in and put the device in, and then they go back to where they are, and then the device ends up in a closet because people forget how to use it, or the staff turns over, or whatever the situation. The more people that can learn about technology and support people using it, the more it's going to be sustainable. So that's our belief, is that it needs to become embedded throughout our system and culture as a viable and important piece of providing services to people with disabilities. And DDS is very supportive of this endeavor. They have funding for the assistive technology and the assessments, and they have just started a pilot program that's going to start February 10th on the whole remote monitoring system of monitoring somebody's movement and safety when you're not there at the house. So they're starting that notice of opportunity, or that program pilot in February.
I think that sounds great. I have a hard time dealing with my own technology right here. But how are you dealing? I mean, this is not a restaurant. We're dealing with people's lives and them and their health. How do we make sure that we have enough people in the pipeline who are going to be working these jobs and helping people out? That's kind of where I'm getting at with this one. But looking down the road, I think it's awesome as to the technology and stuff that we're working with.
There is a severe staffing crisis throughout the whole country, not just through Connecticut. We work in four different states besides Connecticut with our Assistive Technology Center, so we see that everywhere. And that, again, is why assistive technology is important, because it can help augment those shortages of staff. We have some pilots going in our group home to help the staff when there isn't enough staff in the home, to help get things done and help keep people safe with technology. So I think, again, it's a combination. There's not one answer.
Thank you very much.
Okay, Doris, I believe you have another question?
Yes, actually a comment. One of these speakers, and I'm sorry that I didn't catch your name. I'm in the middle of parenting right now as well. She mentioned disabilities. We need to, as a state and nationally, really define disability. I cover the spectrum with education as a self-advocate, a person with disabilities. There's IDD, and there are other disabilities that have nothing to do with IDD. So when we're saying disability, and the question was asked of Pam, we need to define what exactly, which disability you're questioning or wondering about or need to more information about, because IDD is not the same throughout the spectrum. If we can just do that, we as parents from birth to 3 and on have that difficulty in the school systems, in the justice systems. We were just involved with the Police Accountability Task Force as well, to clearly define what it is you're reaching for, trying to understand. I wish that this task force were to invite the Director of Disabilities, Developmental Disabilities, Walter Glom, who has a length of years of experience with the Down Syndrome Council and our council, and a parent as well. And he can define for you. He is with ACL nationally, and he can define better for you and better support, and also support this task force and in your endeavors. Thank you.
Okay, thank you. Milo, you got another
Yeah,
question?
thank you, Doris, for that clarification, because I think what I'm struggling with as a member of this committee is, as I was telling Pam, this is such a broad spectrum that we're dealing with, and not knowing in the end when we do our report, what is the exact objective? Is it, can it be one significant need within each category of disabilities? Because it's going to be different, as Doris was saying, depending on which, we had Alzheimer's experts come in. We have had parents of children with autism. So I think that is one of the things that seems to me, if we don't have clarification on that going forward, it's going to be difficult to narrow the direction that we're going in to come up with what the most significant needs are. I don't know if anybody else.
If I may, I put in the chat room, and I don't know if you have the access, but I uploaded the link for the council's .gov site and our 5-year plan. And although it's varied, we all are individuals. It does concisely address the needs of communities statewide, which include transportation, which include self-determination and various other challenges and supports. So I invite all of you to really look at the council's 5-year plan as well, and to just have us speak with you and address your questions, and let us have a voice in these meetings. Thank you so much for asking.
Thank you. Anybody else have any questions? The only thing, yeah, first of all, Pam, very nice presentation. I was introduced to Midstate way back in 1990, and what I saw in the what you folks did with Special Olympics, with your own soccer team back then, I thought that was a great start, and I applaud what you're doing for everybody to have a good independent living skills, living it in their own places, on getting them to and they be independent on their jobs. I'm hoping one day, personally, they can that everybody can have independence, not just you guys, but everybody, where they can just take the bus to any type of transportation, any place they want to go, and just plain enjoy life and not be looked down on, which in society, that's a very, very heavy crime in my book. But like I say, you guys have come a long way, and I'm always hoping that the future will be even better. Thank you.
Thank you.
Win, are you there?
Yes, I am.
Thank you.
So thank you let me turn on my video. Hi, everybody. Thank you very much for the opportunity to speak with you this morning. As I introduced myself earlier, as the executive director of the ARC, I'm also the father of Nick, our 31-year-old son with an intellectual disability and an intractable seizure condition. The ARC's dedicated to protecting the rights of individuals with IDD and promoting opportunities for their inclusion in the full lives of their community. I'd have to say, starting off, and I'm very grateful for this invitation. I think that this committee this task force has taken in a tremendous amount of data from a lot of different places. But I'd also like to note that we're in a very, very different place right now than where we were when the task force was established. While Connecticut fared much better than many other states, COVID-19 has shed a lot of light on the frailty of our system of supports. In particular, settings thought to be quote unquote safe were not that safe, notably large, insular, congregate settings. With a tremendous amount of thanks to the legislature and governor for adopting a budget that enables providers to pay higher wages to direct support personnel and other employees, we now paradoxically face a workforce shortage, making it extremely difficult for providers to onboard individuals just returning to services, never mind expanding their services. The staff shortage also makes it extremely difficult for individuals, parents, and guardians to execute a plan to get to a better place than where they're at now by self-directing an individual's supports. And then finally, Connecticut's real estate market has taken off, resulting in extreme difficulty for the state in developing anything related to a 24-hour residential setting out of existing housing stock because of how the real estate procurement rules are inside the state. But while I'm referencing COVID-19, this system has been fracturing over a much longer period of time than just the COVID era. So I'm going to give you an example. In 2018, we used our mailing list to survey list members, and the list members are individuals with IDD, parents and family members of individuals with IDD, guardians of individuals with IDD, and other members that might be providers or agency employees, elected officials, or just people interested in what's going on in the IDD community. And we reached out to 3,700 people with a survey, and the survey was constructed to solicit satisfaction or dissatisfaction with employment and day services. 280 list members responded to the survey, which is about 7.5% of the list. 4% of them were individuals with IDD. 75% were parents or family members of individuals with IDD. 7.5% were guardians, and 12.8% were in that other category. The age distribution is pretty interesting, and it does match the topic of employment and day services. So the age distribution was 27% were the individual that the respondent was answering the survey for was between 14 and 21 years old. So that's school transition years. 47% were between the ages of 22 and 35. So those people that had made a very recent acquaintance probably with adult services. 14% were between 36 and 50, and 11% were 50 or older. 125 respondents identified a secondary diagnosis to IDD, and the aggregate number of secondary diagnoses that were identified was 29. Autism was identified 47 times. Down syndrome, epilepsy, anxiety, and cerebral palsy were each identified 8 times. 66% of the respondents identified high behavioral needs as the reason for their individual with IDD having a LON score of 6 or higher. Medical needs were identified by 32% of the respondents. High sensory needs were identified by 27% of the respondents. And an other need was reported by 23% of the respondents. My point in giving you all this data, and I know the data is boring, the real point is that the range of needs is clearly getting more complex than what it was 35 or 40 years ago. And I use the reference of 35 to 40 years ago because that's basically when Connecticut did a very progressive thing, and it marks the advent of Connecticut's community-based service system of support. However, our system of support just has not kept pace with this wider spectrum of need. We need a system that recognizes this breadth of need and offers access to support options that enable an individual with complex needs to access their strengths to build the life they would like. Our present system does not do this consistently due to its heavy institutional roots. And I'll just sort of plain language describe what I mean by institutional roots is, and this is a harsh comment and I apologize for it, but we have just a few sizes of things on the shelf to accomplish the job for most people. We don't have enough variety. And we tend to also be highly wed to licensed settings, which come with large administrative burdens. In particular, we need to learn from other states' experience in providing supported living in unlicensed private homes. We need to look at their experience in trying to rebalance a residential system to better align supports with needs while promoting appropriate measures of independence. And we need to look at adopting quality measures that emphasize and reinforce an individual with IDD's choices, progress, and navigation toward defined IP goals in skill development, personal care, safety, employment, and social skills, and also keep track of where that progression is leading them in terms of things like hours volunteered in the community or hours worked in the community and the wages that they earn. We also need to examine changing some of Connecticut's practice to not only measure those outcomes on a consistent and periodic basis, but communicate them to system stakeholders. We need to enable behavioral and medical supports to be accessed when they need to be accessed based on history and individual plan documentation. Right now, there's an imbalance in the system between offering those kinds of supports only to those people that have residential funding, not to the people that have day and employment funding. And that needs to be rectified. We conducted that survey in 2018 because we started to hear from a lot of parents that they were having difficulty finding a day and employment program that they were comfortable having their loved ones in. We need to expand direct support personnel, education and training and behavioral supports and med certification. These are problems that are well known and understood, but we need to potentially take some of the federal money raining down on the state and use it to buttress that in order to get better lives for people with IDD. We need to do some coordinating efforts between families and individuals, DDS, the Department of Aging and Disability Services, in particular their vocational rehab unit, and the State Department of Education, in order to meld together a template for the transition period from school age to adult services. And that should be based on person-centered planning and aligning expectations and improving system navigation, employment outcomes, and resource allocation. And then we need to review and revise our quality service review practices to concentrate less on the settings and more on the individual being supported. And research and adopt inclusion and integration standards to enable development of new housing schemes, which could include intentional communities. It could include a number of different things. So I thank you very much for the time allotted for me to present these ideas, and I'd be happy to answer anybody's questions.
Is there anybody that has any questions for Wynn? Anybody here? Wynn, I just want to thank you for the presentation. What I at the beginning part, I think it comes down to priorities that we need to have as human beings. And don't get me wrong, ladies and gentlemen, I'm a big sports fan, always has been. But we also, have to think if we can spend so many dollars on athletics, I think we can hopefully in the future, very near future, we can find the resources to help people who are desperately in need. Thank you, Wynn, for your presentation.
Thank you.
Our next speaker, Attorney Deborah Dorfman, who's the Executive Director for Disabilities for Rights of the State of Connecticut here.
Thank you so much. I really appreciate the opportunity to come and speak with you today. I was invited to come and talk with you about Disability Rights Connecticut's perspective on the short and long-term needs of people with intellectual disabilities. And so I want to go over that with you today. I do have a PowerPoint, and before I begin, I just want to give you a quick overview. So next slide, please. A quick overview of what I'm going to address today. And that is first just give you a brief overview of what Disability Rights Connecticut is, and then a framework for the context for identifying the long and short-term needs of people with ID in Connecticut. And then to focus on three particular areas. We've spent some time today talking about focus. So I hope to be able to do that at least for you from the perspective of Disability Rights Connecticut, or we call ourselves DRCT for short. And those three areas are kind of, I think, overlap with some of the other speakers, but with the broader range and increased community-based services and supports and housing options that are accessible, affordable, and integrated, timely access to health, mental health, and dental care, and then competitive integrated employment and meaningful integrated day services. So if you could go to the third slide, please. So just a brief overview of Disability Rights Connecticut. We are a statewide private nonprofit legal agency for people with disabilities throughout the state of Connecticut. We are the federally mandated protection and advocacy system. So some of you may have been familiar with the agency that used to be the protection and advocacy system called the Office of Protection and Advocacy System. That was a state agency. We are not a state agency. We are private. And we've been in existence since around 2017. And we operate under several federal mandates. And the one that's relevant to the discussion here today is the Developmental Disabilities Assistance and Bill of Rights Act of 2000. And that's a federal law. And we have several other similar laws that we operate under. But again, this is the one that's relevant for people with intellectual and developmental disabilities. Next slide, please. So before I begin and talk about the three top areas, at least from our perspective, that need to be addressed, I wanted to put a framework around that to give you a context of why we think these are the key areas. And what I'm going to say isn't really new. It's the same conversation that people are having nationally. And I'm relatively new to DRCT. I just began in February, but I'm not new to the protection and advocacy system or disability rights. I've been doing this work for almost 30 years and have worked at 4 different protection and advocacy systems around the United States. So I do come with a national perspective. And so one of the issues that I think we have to think about here, and this is true again nationally, but it's also the case here, is that the majority of people with ID in Connecticut do reside at home with their families. According to the data that DDS published in June of 2021, shows that 57.9% of the people at least receiving services from DDS. And I will just note that the eligibility criteria for DDS here in Connecticut is very, very narrow. And that's another issue perhaps for another day, but that means a lot of people who have developmental disabilities aren't included. It's really people with intellectual disabilities. I just wanted to note that. And so this point is important because as people are living longer and their families are getting older and may not have the ability, and people's needs become more complex, they may not have the ability to support their family member at home. Or the individual may want to have an opportunity to live independently. And so we really have to think about that now. We can't think about that tomorrow, I mean, and late, or push it off till later, because as we do that, the needs of people will increase because people get older and older and older. And again, this is not a new problem, but it's a crucial one that we have to really think about immediately in order to address the 3 categories of problems that, or issues that I've raised. The other thing is that I think it's very crucial that Connecticut needs to, I've only been here for about 10 months, but I can say in the 10 months, it's very clear to me that Connecticut, while certainly making, some great efforts towards implementing, integration and inclusion as required by Title II of the Americans with Disabilities Act and Olmstead, Connecticut still has a long way to go. And that is not just in the context of, housing, because that is a very big key, but every aspect of living, from being able to have inclusive work opportunities, inclusive opportunities of how people spend their days generally, and all aspects of life. And I think there's a lot of work to be done here in Connecticut. And so with that framework in mind, I'd like to just go over the 3 sort of key areas. So the first one, and I'm sorry, next slide, please. The first one is, as I mentioned, there needs to be a broader range of increased community-based services, supports, and housing options that are accessible, affordable, and integrated. One of the things that I have noticed since I've been here is that there is an over-reliance on institutional care for people with intellectual disabilities. That is one of the issues. There's also, and many of my comments again echo the other speakers from earlier, but there's also not an array of community living options that we really need. And part of the problem, as Wynn mentioned, is that the regulations and rules are really prohibitive for people to be able to live, for example, in a companion home or in some other living arrangement other than a group home, because of the restrictions and the requirements, it really makes it onerous and hard for people to do that. And you can actually really see in the data that DDS publishes really illustrates that. If you look at again, the most recent MIR Management Information Report from DDS, you'll see that only 2.28% of the people who are being served by DDS are using companion homes, yet 20.98% use group homes. And the companion homes are this whole great opportunity for people to live in the community, and other states do it and have a lot more flexibility. So I do think and agree that that's something that Connecticut should be looking at other states and other models to see what works and make sure that people get the services and are able to safely live in the community. There are also long wait lists for DDS services, and so we need more services. We need more waiver slots. If we don't have these, this kind of goes back to that original point. If we don't have these, parents are not able to plan, families are not able to plan for how things are going to, work out in the future for their loved ones who, when they're not able to care for them or something happens. And, people shouldn't be having to wait until there's an emergency situation. That is not the way to plan, and not good for the system. So, and there also needs to be, and we've talked about this, sufficient provider capacity, so that, we've talked about the shortages, and that is, I agree with that wholeheartedly. I think one of the other things that we need to do is to really develop the capacity for service providers to be able to take on people who have complex medical and behavioral needs. So, and that's part of the long-term planning that I talked about, but it also will enable people who tend to get stuck in institutions or stuck in the hospital because there's not somebody there's not the provider capacity to provide the, nursing care that a person might need, or behavioral supports that people might need in order to be able to go back to a community living arrangement or to transition to the community. And so this too is really, really crucial. Next slide, please. And I'm sorry, the one after that got behind. Next slide, I'm sorry. Thank you. So a couple proposed solutions around this is that I think it would be really important to not only develop the broader range of services and have more of them, but make sure that we really are focusing on having integrated, accessible, and also affordable housing. That's really important. I think it's also another thing that will be important in doing this is to make sure that there's enforcement of state and federal fair housing laws and state affordable housing law. That is to avoid communities who don't want people with disabilities living in their community, and to make sure that there's efforts to not allow that kind of thing to happen, and then to change the regulations and rules so that we can make providing care and support in companion homes and similar arrangements more viable, and also to provide sufficient information to people with intellectual disabilities and their families so that they can make an informed choice about whether they want to live in the community. That's also very, very important. Next slide, please. So I want to next talk about the issue around timely access to adequate health, mental health, and dental care. This is important because everybody needs these things, and we want to make sure that people with intellectual disabilities have the same and equal access to these services as people without disabilities. It's also really crucial, going back to the framework that I mentioned at the beginning, to have these services, particularly as people are getting older and their needs are becoming more complex. We've got to have these services in place. There is, some of the key problems that we've identified are the lack of access to medically necessary habilitative mental health care for people who have intellectual disabilities and co-occurring mental health disabilities. We also need to have, there are also problems with just finding, again, this is another provider shortage problem, but making sure that there are the providers who have the expertise to do this work and who are willing to take on in the patients who are people with intellectual disabilities. And also, you know, currently there is a potential for a risk that there could be further barriers to access to these kinds of services for Medicaid recipients if we go to a situation where we have capitation in primary care. And so next slide, please. Some of the proposed solutions would be to make sure that there is better coordination between DDS and DMIS and also local providers through the use of across systems MOU that would ensure coordinated care and support and crisis planning for people with dual diagnosis of ID and mental health disabilities, and also to make sure that we have a process to have qualified and trained interdisciplinary teams of people who can really provide these services to people who are dually diagnosed. This is absolutely crucial. If you don't have that, I can tell you from having dealt with this issue extensively in Washington State, people will end up in your state psychiatric hospital and people with ID, and that is not an appropriate placement for people to end up. And also developing a sufficient cadre and also incentivize qualified providers to provide Medicaid covered care for people. And then, of course, avoiding capitated rates of service in Medicaid. And then next slide. The third topic that I mentioned is the need for competitive integrated employment and meaningful integrated days. Some of the key problems is that very few people with intellectual disabilities are actually employed. So what we can see by DDS's own data that since 2014, we see a steady decline in the people who are employed, and we see an incline of the people who are in a day service option, or sometimes it's referred as day habilitation, but here it's day service option, or DSO. And we also know that very, very few people with intellectual disabilities are in competitive integrated employment, which means that, you know, very few people are making above like minimum wage or above, and very few people are really in a truly integrated employment setting, having opportunities to be part of the community. So again, just to point to the DDS data, in the June 2021 MIR report, it was reported that only 1.59% of people being served by DDS are actually in competitive integrated employment. We also know that many people who have a higher level of need score often because of behavioral problems, particularly behavioral problems, but also sometimes people who have high medical needs or a combination, many of those individuals are denied the opportunity to have competitive integrated employment and are really relegated to either some sort of segregated employment or to no employment and some sort of DSO option that is often segregated. And people who don't have employment options, like I mentioned, they end up in segregated or mostly segregated day programs. And the programming and the employment is often not based on individual assessment of what the person needs or what the person wants, most importantly. And so people end up doing things, shredding things or folding newspapers or doing nothing, just sitting there for hours and hours each day. And that's not necessarily what they want to do. So next slide, please. So some proposed solutions. One would be to make sure that people are provided sufficient information in their families so that they can make informed choices in terms of whether they would like to be in receive competitive integrated employment opportunities. A lot of people just have not been provided with this information. Also, a key thing is to substantially expand the opportunities for people with intellectual disabilities so that they can have these opportunities to have competitive integrated work. And then ensure that those people who might not want to work or may be retired or for whatever reason may be not able to work, that they still have the opportunity to participate in daily activities that are integrated and that are based on the things that they need, but also what they want to do, rather than literally having to sit in a DSO program at a table all day waiting to eat lunch and then waiting for the van to come and get them and take them home. Finally, I think it's really important, and I echo what the other speakers say about this, but there has got to be some active and meaningful collaboration among the different state agencies. Right now, they operate in silos, and they need to coordinate with each other, particularly DDS, BRS, and the Connecticut State Department of Education. So thank you so much. I know I took a little too much time, and I appreciate everyone's time today. Thank you.
Okay, is there any questions here for Deborah? Go ahead, Pam.
Thank you, Deborah. That was a great presentation. I think one of the things as we as committee members have sat through a lot of presentations, like Nicole was saying, and received a lot of information. One of the pieces that I think as you're talking is missing, because we keep hearing there's a lack of services, that there's not services for this population, that it's not offered. But I don't think we're asking why people are not offering it. And that's a missing piece. Their providers are reluctant to offer a lot of these services. And I think we need to hear from providers why they're steering clear of these services, because until we address this issue, that nobody's talking about, it's going to continue to not happen because it's just not being addressed. So I think that's something that we as a committee might want to talk about after, is how that's going to happen. And then again, with all of your presentation, and we need to looking at how do we create system change? We've sat for years and looked at all of the issues, but how do we change a system? Like, how do you do that? Because if we don't start again to have some recommendation, or this is how you do it, or this is what we should do, we're going to be here in 3 years doing the same thing. So that's just my comment. Thank you very much.
Okay. Is there anybody else that has any? Go ahead, Myra.
Sure. Thank you very much. I thought that was very informative. I also would like to thank your agency's work for extending the age out from 21 to 22. I think that was really necessary and needed. I'm grateful for that as a parent. And I know in the beginning of your presentation, you mentioned the 57.9% of people with ID are still residing at home. I would be interested to know within that percentage, how many are looking for placement and are suffering right now in a crisis of the age out is a serious issue that is only going to increase because of change point years and diagnoses. 15 years ago, there was an incredible jump. It's an epidemic, particularly in the autism community. And the numbers of age out are about to hit Connecticut in a much greater way, and we're already behind the 8 ball. So I think as a member of this committee, not just as a parent in an experience level dealing with this, I think overall, we need to be preparing for that, but we're so far behind the 8 ball, and it seems to all go back to staffing. And when I say staffing, I don't even want to use that term. What I mean is quality providers that are educated, like you're saying, that have multiple different areas that they can work within, if you have several different level of need in one place. And we also, I know you talked about the institutional setting, which I think I would really like to see the idea of institutional setting and the whole model of it changed to natural, more for, let's just say for the more significant level of needs, let's say 6 through 8. If those people need services, there are models out there that have residential services that have continuity that allow the individual to gain skills so that later on, I mean, I'm talking at school age. So later on, when they go to age out, they can get more jobs. They can be more productive in their community. They have a much higher communication. I think the one of the big problems that we have in Connecticut is those quality services in the educational age, let alone the adult, because it all flows through. If they're getting great services when they're younger, they're going to have more skills when they're older, so they can be more productive and have better quality of life. And I think sometimes with the more severe level, there are some models out there that are providing a high level of really educated staff, and they're bringing down numbers of severe behavioral, and getting people off of lots of medication and helping them to be more productive through lots of different expertise in the area. And I really think it would be great for this committee to have a model like that come and share some of their success in that, and in, you know, residential and day programs, schooling, because it's got to start at a young age. I mean, like we were talking about, there's so much here. But if we're trying to help an adult that has a severe level of need, but they haven't gotten the skills when they were younger, we are, you know, the parents have them home instead of in school with services once they age out. And now the level of behavioral intervention and psychiatric stuff is going to increase. So my thought is being more aggressive with services at school age, so that by the time they get to age out and we have more services there. I mean, we're closing group homes where we have some serious issues. I think it's a little more severe than we realize. And in the next few years, there's going to be a lot higher number of age out individuals with intellectual disability. So I appreciate everything that you laid out. Thank you.
Thank you. And
Dawn, go ahead.
Attorney Dorfman, I just want to thank you so much because you brought a lot of truth. And I'm in agreement with Pam with regard to system change is necessary. And I appreciate the fact that you have experience from many, many states and have worked in advocacy for as long as you have, because it takes a lot of commitment. It's very hard work. I have a child who is IDD and has medical complexities. And I have seen system, despite forums where administration says we are going to be person-centered and not system-centered, that has not resonated within management. And I speak to the elephant in the room. I agree with you, Pam. I think system change for the department. And I can't speak to other departments, although I'm probably sure there are other departments that need a change too. I believe we need to start with some of the very clear principles that you have outlined in this presentation. And I thank you as a member of the task force, because we needed something to pull things in. Yes, there are situations where intervention at a young age is possible. The problem is there's so much going on in the wind and nobody's capturing it and integrating it, streamlining it so that the majority of people, whether it's the elderly or it's the IDD community, and you have these agencies that are working together, but there's so many things in the way that are prohibiting progress. And I thank you, ma'am, for your courage and your integrity.
Thank you so much. And if it would be all right, I'd just like to say, I really appreciate all of your hard work and being, your commitment to being on this task. This is really, really crucial. And what I can say to you is that Disability Rights Connecticut is committed to systems change. That is, in fact, of our work. And there are, definitely ways in which the system can be changed. There are experts throughout the United States who can help with that. We are committed to that, and we can help with that. And we would like to work with you to make that happen. So thank you so much.
Is there anybody else here that has a question? Okay, Deborah, thank you very, very much for coming to speak. I think the word, what you used, the word segregation. It isn't just with people with special needs. It's all throughout everybody, whether it's color, nationality, religion, you name it, it's there. And unfortunately, until attitudes are changed, it starts with us as individuals to make sure that people are treated with respect, regardless of whether it's age or anything. It's kind of like the old rule: respect from others begins with oneself. Thank you. The next thing is on the agenda is a meeting date, and is anybody prefer to have a meeting date? We say, I know it's going to be in January, but is there a preference, like another Wednesday around 9 o'clock in the morning? Is that okay with everybody? Matter of fact, people who are on Zoom, please participate on this one as well, if you have an idea.
Are we looking at a month out?
Like in January,
January?
around the same time, like a Wednesday. Okay, mid-month. Okay, so like the second Wednesday in January.
That would be
Okay.
the 12th.
Yeah, January. That's January 12th.
Yep.
Okay. Does anybody here object? And people in Zoom, if you please participate on this one too. Okay, then. So the next meeting will be Wednesday, January 12th at 9 a.m. in the morning. Okay, so is there any, do we have anybody for public comments? Is anybody who listened that out there that want to participate, make a comment? Okay, so the only thing we have on the agenda is the for other business, which was services in urban versus rural parts of the state, nonprofit alliance, social enterprises, physician roles. We don't really have much information on this now, but hopefully very soon we will have some more information on it. Thank you.
I'm sorry, if I could just add, Mark, I think we need to add, if these are additional topics that we're looking at for the future, I would like to see added the providers and why the system change, why they can't provide the services, like why are the services lacking? I think we have to ask the people in the system of why it's not happening, and hear from them, because if we don't hear, we're not going to be able to recommend how to make it happen. If we don't. And I think that Nicole asked for those schools to present. So I think that might be something, I mean, I remember before COVID, when we were together, you brought it up, that we should probably put that on the list so that we have a full role. And then I think we have to look at this, take all that stuff and look at system change. I think we have to have a working meeting where we're not having somebody present, where we're looking at what we've already gathered, where are the gaps, what's going on, and try to put it together in some kind of a piece so we can see what we've been looking at over the last couple of years and start to make a plan and recommendations and like where we're going with it. Because I think, like everybody said, we've seen a lot of information over the last couple of years. We've had a lot of people come in and speak. I think we have the information with us. We just have to sit down and go through it and figure out how to put it together so we can actually see where the gaps are and what the reasons are why the gaps are there. If that makes sense.
I don't know if I can.
Go ahead, Mike.
Thank you. I wanted to comment on that because I agree with you, as I stated before, but I think there's one particular school, and I am speaking from personal experience because I have a child that is the most significant level of need in Connecticut, and we exhausted every service here, and it wasn't helping him. He was on a 3-to-1 ratio behaviorally, and then he was psychiatrically admitted for 6 months at the age of 5. And to go from that to being off almost all medication, communicating with a AAC device, looking at vocational programs, when I was told he was never going to be able to be educated. And I really contribute that to the schooling program. It is innovative. They've won national awards. They're setting up in other states to help on all of these levels implement new systems. And part of their staffing solution is creating partnerships with colleges to help give incentive to their staff who have a desire to want to continue their education so that there's less turnover and there's more education in regards to behavioral, significant behavioral needs that can be implemented in a safe way and in a very natural setting that gives my son so much more freedom, which is what I want. I want him to be home. I want him to have a job. I want all these things like we all do. And for this population across the board. But the truth is that we really need these experts that are successful at the very most severe level to say, this is what we did when everything else wasn't working. And this is the success we've had. So thank you.
And Beverly Henry, you have something to say here?
I'd like to make an announcement for members of the public who is watching or they're currently on Zoom. For the next meeting, you will use the YouTube live link, and only members of the task force and presenters will be allowed in Zoom. So for members of the public, you click on the calendar, the CGA calendar, you open the meeting, and there will be a YouTube link, and you click on that and you can watch the meeting. And that's a way of controlling the folks we let into the meeting. If they're invited speakers, they will be, but any member of the public will be able to use Zoom, YouTube Live, or watch it on CTN if it's recorded.
Happy and safe New Year to everybody, and hopefully we'll see everybody right after the new year. Meeting adjourned.